In this session, we are going to be talking about the randomized controlled trial. The objectives of this session are to look at the role of RCTs in the evidence pyramid, to look at some errors in research studies, to understand the key elements of an RCT, the strengths of an RCT, and what internal and external validity of a study is. The randomized controlled clinical trial is considered the gold standard for evaluating the efficacy of treatments. If you look at the evidence pyramid, randomized controlled trials are ranked very high, and that is because they provide a high quality of evidence with a relatively low risk of bias. What happens in an RCT? A group of individuals who meet the eligibility criteria are randomized into experimental and control groups. Study procedures are standardized and precede the outcome. Outcomes are assessed without bias, and results are compared between the groups. This is a consort diagram showing the flow of participants through a typical randomized controlled trial. So participants are assessed for eligibility and then randomly assigned to receive either the experimental or the standard treatment. There are some protocol violations. Participants receive the treatment, and finally, outcomes are compared between the groups. So where do we go wrong in research studies? Errors can be systematic, known as bias, or random. Errors in the design, conduct, or reporting of studies leading to systematic deviations in results result in bias. Examples of these include selection and allocation bias, treatment bias, performance bias, assessment or evaluation bias, and attrition bias. We will look at each of these in the coming slides. On the other hand, random errors or statistical errors arise because studies are carried out in samples rather than entire populations. These are inherent errors and can be controlled by adjusting the sample size. What are confounders? These are known and unknown factors which may have an impact on the outcome of a participant on a trial. For example, we know that smoking is a risk factor for pancreatic cancer. We also know that smokers tend to be coffee drinkers. If we conduct a study and find an association between coffee drinking and pancreatic cancer, we need to be sure that this is a direct relationship and is not because of the association between coffee drinking and smoking. So here, smoking is a confounder in the pathway between coffee drinking and pancreatic cancer. Randomization is a technique to ensure that groups in a study are comparable at baseline with respect to known and unknown confounders. The only difference between the groups is the intervention. Randomization removes conscious and subconscious biases, which could have otherwise resulted in a selection bias. With randomization, each participant has the same chance of being allocated to any of the groups. The allocation is not determined by investigators, clinicians, or participants. So how do we randomize? The easiest way to randomize is what we call simple randomization, which is done by tossing a coin or by using a table of random numbers. However, these techniques could still result in some imbalances between groups, particularly if the sample size is small. A more advanced way is to use permuted blocks. This consists of blocks of varying sizes, for example 4, 6, 8, 10 or more. And randomization is carried out within each block. So if you had a block size of 4, the random sequence could be anything like AA, BB, AB, AB, or BA, BA if you had to randomize between two groups A and B. What this ensures is that at the end of each block, you have equal numbers of participants in either of the groups and imbalances are removed. Sometimes we know in advance that there are some important prognostic factors which could affect outcomes. For example, in a study of breast cancer, we would want to account for tumor stage and HER2 receptor status. Here, a better way to adjust or prevent imbalances is to use stratified randomization, where for each stratum of the factor, a separate randomization is carried out. Some techniques such as alternation, using odd or even hospital numbers, using dates of birth, or the first letter of the surname appear to be random. But randomization must be unpredictable, and therefore these are not truly random methods and should not be adopted. Once we have decided to generate a random sequence, we need to prevent knowledge of upcoming allocation, because this may bias an investigator into allocating participants with better prognosis into the experimental arm. This is known as an allocation bias. Allocation concealment overcomes this allocation bias and prevents knowledge of upcoming allocation. The simplest way to do this is to generate a random number sequence and insert sequential numbers into opaque sealed envelopes such that a single envelope is opened every time a patient needs to be randomized. More advanced techniques include central randomization methods using the telephone, voice response systems, or the internet. Is allocation concealment important? This study looked at 250 randomized trials across 33 meta-analyses. They found that when allocation concealment was adequate, the study reported no treatment effect. Whereas in studies where allocation concealment was either unclear or inadequate, the treatment appeared to be significant. So remember, randomization actually depends on two interrelated processes. The first step is to actually generate the random sequence, and the second is to find a technique to conceal foreknowledge of allocation of the participant. Does randomization work? So in this study, roughly 200 participants were randomized to one of two groups, and you can see that the sex distribution, age distribution, and distribution of type of surgery were almost identical between the two arms. So randomization does distribute most known and unknown confounders equally between groups. Now, if you have knowledge of the treatment arm, that is whether you're in the experimental arm or the standard arm, individuals may behave differently. For example, participants may report symptoms or outcomes differently, and this is what we call a performance bias. The investigator may treat patients on the experimental arm better. This is known as a treatment bias. And evaluators may report more favorable outcomes in patients who are on the experimental treatment. This is an assessment or evaluation bias. These problems occur more when you have subjective outcomes or soft endpoints, such as where investigator judgment is needed or when the participant has to report outcomes. They are less common when you have objective outcomes such as mortality or progression of disease. So blinding or masking is a method to prevent study participants, healthcare professionals, and those analyzing data from knowing who is in the experimental group and who is in the control group, so that they cannot be influenced by such knowledge. We do talk about single blind, double blind, and triple blind studies. Remember that almost everybody who is part of the research team can be blinded, and this includes participants, researchers, data collectors, outcome adjudicators, and data analysts. Blind as many people as possible, and rather than using these terms, report exactly who was blinded. So this is a typical drug trial where there is an active tablet and an active capsule, and for each of these there is a matching placebo. So each participant in the trial receives a red tablet and a green capsule, and no one is aware of who is in the experimental arm and who is in the standard arm. Contrary to popular belief, it is possible to blind surgical studies. This study, published in The Lancet, compared laparoscopic with small incision cholecystectomy. Surgeons were blinded to the patient they were operating on. Patients were not informed about what surgery they had undergone. And to maintain blinding in the post-operative period, the patient's abdomen was covered with blood-stained dressings in a manner which allowed no one to figure out what surgery had actually been performed. This study showed that cholecystectomy, whether performed laparoscopically or via small incision, had no impact on most post-operative outcomes. Is blinding important? This study looked at the impact of blinding on the results of a trial in multiple sclerosis patients. It compared 3 treatments for multiple sclerosis. Unblinded neurologists found that plasma exchange was significantly better. Blinded neurologists found no difference. The same study that I alluded to earlier, unblinded trials reported a significantly higher treatment effect as compared to those which were blinded. So remember, blinding is different from allocation concealment. Blinding is prevention of knowledge of assignment after the actual allocation, and the goal is to prevent performance, treatment, and evaluation bias. Whereas allocation concealment is prevention of knowledge of upcoming allocation at the time of randomization, and the goal of allocation concealment is to prevent selection bias. While blinding cannot always be carried out, allocation concealment can and should. Now, any intervention in a trial needs to be compared to one or more other interventions, and these could be standard treatments, which are active controls, or placebo. And this is because the effect of experimental treatment should be distinguished from natural improvement over time or a placebo effect. Does the placebo effect exist? This study looked at treatments for osteoarthritis of the knee. And they randomized 180 patients to receive either arthroscopic debridement, arthroscopic lavage, or placebo surgery, which included only skin incision and simulated sounds. And they found no difference in pain outcomes between any of the treatments, suggesting that the placebo effect does exist. Is a placebo control ethical? Only if there is no standard treatment available. Wherever a standard of care exists, it must be offered to participants. If there is no standard of care anti-cancer treatment, then it is ethically permissible for the standard arm to be best supportive care plus placebo. Another problem in trials is attrition bias. Participants may be withdrawn from a study because of various reasons, such as deviations from the protocol or losses to follow-up. Now, these ideally should be minimal and should be randomly and equally distributed between the various study arms. If there are systematic differences between groups in the loss of participants, this could lead to a bias because the groups may no longer be comparable, and more importantly, the reason for withdrawal may be related to participation. For example, if a study treatment is particularly toxic, or very difficult to comply with, you may have higher numbers of withdrawal in that arm. To bypass this, we use the intention to treat analysis, in which we analyze patients in the group to which they are randomized, irrespective of the treatment they receive. This retains the balance in prognostic factors arising from the original randomization. It gives an unbiased estimate of treatment effect and admits non-compliance and protocol deviations reflecting a real-life situation. As an alternative to this, we use the per-protocol analysis, where we only analyze those patients who are fully compliant with the randomized intervention. While this evaluates the true effect of the intervention under ideal conditions, it is more prone to bias because, as we have already discussed, the reason for the non-compliance may actually be related to the treatment. Another problem is treatment switching during a trial, where those randomized on the placebo or standard care arm switch to the experimental treatment after progression. Now, this could either be planned as part of the protocol or unplanned. The problems with this are it can confound the overall survival benefit, especially if there's a selection bias in who switches over. This kind of data needs special statistical inputs for analysis. Having discussed the systematic errors, let's briefly look at the random errors. So statistical errors or random errors arise because we do studies in samples rather than the entire population, and we try to infer from the study results and extrapolate to the population. So a type 1 error, also known as an alpha error, means rejecting a null hypothesis when it is actually true. For a superiority study, this would mean accepting a false positive result. A type 2 error or a beta error is accepting the null hypothesis when it is not true. And for a superiority study, this would mean accepting a false negative result. Both of these can be avoided by ensuring adequate sample size while designing the study. So the strengths of an RCT are that there is control of confounding factors, both known and unknown. Temporality is assured. We know that the intervention came first and the outcome came later, and a cause and effect relationship can be established. And an accurate estimate of risk is obtained. The challenges with randomized controlled trials are establishing their internal and external validity, which means, can you apply the results of the trial to your patient? Now, internal validity is the extent to which the design and conduct of the trial eliminates the possibility of error, such that the observed effects can be attributed to the independent variable. On the other hand, external validity refers to the extent to which the results of the trial are generalizable to the real-world population, and this is also known as applicability or generalizability. Without internal validity, external validity is irrelevant. So how do we improve internal validity? We have already discussed systematic and random errors in trials. And the way to improve internal validity is to minimize these errors. So use proper randomization techniques and allocation concealment. Use appropriate controls. Blind wherever possible. Limit attrition. Apply an intention to treat analysis. And ensure adequate sample size. How do we assess the external validity of a study? Look at the setting of the trial, the characteristics of the participants, what types of interventions were used, and how outcomes were measured, and see whether these are similar to what you would apply in your clinical practice. Now, clinical trials have very stringent inclusion criteria and typically accrue patients who have a high performance status and minimal comorbidity, and therefore they provide an estimate of efficacy under very controlled conditions. But when the same intervention is applied in the real world, the results are likely to be different. So real world evidence provides data on effectiveness in routine practice. And we know that for many systemic anti-cancer therapies, there is a gap between efficacy and effectiveness. So this study showed that for many oncology trials, the majority of real-world patients would be considered ineligible, grossly limiting their external validity. In this study, they looked at differences in median overall survival between real-world data and clinical trial evidence for a variety of interventions across many indications. And what they found was that the difference in median overall survival ranged from 2 months to as much as 18 months between real-world and clinical trial data. So in summary, while randomized controlled trials are the gold standard to prove the efficacy of an intervention, RCTs and real-world health outcome studies provide complementary information, and we need to examine real-world evidence after established RCT efficacy for the ongoing evaluation of adopted technologies. Thank you very much.